I am Kate Mostowski, co-chair to the Pennsylvania Cancer Coalition, and I will be your facilitator this morning. So again, this is our June meeting, and it has been 1 year since we have been meeting virtual. So with that, we have gotten very used to this, but we have some new things in store for you today. If you did not see the first slide that was up when you joined, that was referencing if you will be joining this afternoon's PCC meeting, and there's some pre-registration to help navigate us to our proper breakouts. So if you have not done that pre-registration, we'll be doing reminders throughout this morning just to help with the navigation to that as you would be assigned into your designated work group based off of that. So it takes a little bit of logistics for us to do, and so we'll appreciate your patience as we do that, but really look to you to kind of help us along the way. And that does bring us to some new things and opportunities to kind of get us back to how we were meeting pre-pandemic. So once again, jam-packed day. We're excited to bring all of this to you, and we're going to go ahead and move looking at this whole agenda. So as you can see for this morning, we have a great number of presentations and just really good stuff to share with you. We're excited for that. We'll go into a lunch break, and then we will come back at 12:30 to do the PCC portion of our meeting. One of the things as we move into this morning's session, I will just ask of our speakers, just with the kind of content that we do have this morning, to kind of help keep us on time, I may just do a little reminder as we are approaching the end of your designated time slot. So, I'll apologize in advance for that, but just look for some of those reminders either in the chat or for me to come off of mute. And with that, I'm going to actually turn it over to Peg O'Grady, our CAB Vice Chair, to take us through this morning. Oh, and one thing, I will advance everybody's slides, so if you could just let me know when to move to the next slide, I'll go ahead and do that for you. Peg, floor is yours.
Kate, we can't see the presentation.
Thank you, Peg.
Yeah, no problem.
All right, let me just tackle that for a second. Thank you for that, and we will get it right up and going.
What are you seeing?
Yeah, I'm now seeing just all the people displayed. Now I have a blank screen.
Okay.
Hey,
So
if this is when I can see it.
Ron Myers, I can see the slides. Call to order.
Okay.
So can I. Yeah, I can see the slides too.
Okay, then it must be me. Because I'm just getting a blank screen. It says recording is started. That's about it.
Okay.
So, but that's okay. I have another set of slides in front of me. So let's go with conflict of interest and adverse interest. Please know that Act 33 of the Pennsylvania Cancer Control. Oh, there we go. Now I see it. Beautiful. Cancer Control Prevention and Research Advisory Board. No member of the board shall participate in any discussion or decision to recommend grants or contracts to any association or to any agency of the Commonwealth or its political subdivision with which the member is associated as a member of the governing body or as an employee, or with which the member has entered into any contractual arrangement. Board member affiliation listings are signed and dated before the start of each CAB meeting. We're trying to avoid conflict of interest or adverse interest. A member of the board will abstain from participating in all discussions and decisions regarding any issue of an RFA, RFP, grants or contracts, or discussion leading to a recommendation. To avoid any, even the appearance of a conflict, the member should leave the room during the vote on any such proposal, and the minutes of the meeting should indicate the recusal of that member for vote. Next slide, please. This meeting is currently being recorded so that we have future reference. Meetings for this group are public meetings under the Sunshine Act. There is no expectation of privacy of this content. Recording of this meeting will be housed on the pacancercoalition.org site for future reference. Next slide, please. I would like to introduce Rebecca Kishbaugh, who will be going through Cancer Prevention and Control, Pennsylvania Department of Health information, the 2021 budget. Rebecca, thank you so much.
Thank you, Peg. Good morning, everyone. First, I want to start out and talk about the end of an era. And so, yes, it is true. Sharon Sowers is retiring effective July 16th. She has worked in this cancer division for over 11 years with me, and her legacy includes, among many things, the reinstitution of the Cancer Coalition. It was a heavy lift, but today we have a statewide, very active PA Cancer Coalition with over 450 members. So congratulations. The other major accomplishment was the development of a statewide cancer plan back in 2013. We spent a lot of time re-engaging folks and asking them to come back to the table and help us to write this plan. It was developed for 5 years, and we are now already into our second 5-year plan, which started in 2018, 2019. So again, congratulations, Sharon. It was your outside the box thinking and all your hours spent traveling and meeting with previous Cancer Coalition members and asking if they'd be willing to come back to the table. We sincerely appreciate her dedication and commitment to the success of the Comprehensive Cancer Control Program. I know that I will greatly miss her sense of humor, her amazing communication skills, and her witty themes and presentations. I will never forget the annual meeting asking everyone to get on the bus. So best wishes, Sharon, on your next great adventure. Okay, out now back to the budget. So for the fiscal year 2021-22, in May, we did receive our notice of award from CDC. It is basically level funding as we move into the year 5 of our 5-year grant. It covers the three cancer components, which is the Pennsylvania Breast and Cervical Cancer Early Detection Program. That program was awarded $3,118,000. Those funds are used to support DOH staff salaries and benefits, a few office supplies, and the rest of the money goes out the door for contractual services. The second component is the Pennsylvania National Comprehensive Cancer Control Program, and we received a level $351,785. Those funds go to support the 2 required DOH staff positions, a few supplies, and the rest goes to cancer plan implementation activities. And last but not least is the Pennsylvania Cancer Registry. They were awarded $1,050,000, and those funds are used to support DOH staff positions, a few supplies, and some required travel. Maybe this year they will get to go to some of their amazing cancer registry conferences. So the overall federal funding amount that we received for the last year of our 5-year grant in 2021-22 is $4,519,785. That's it. Don't know if anyone has any questions, but that is the overall amount. And I'll turn it back to Peg.
Thanks so much. Next slide, please. So I get the absolute pleasure to introduce you to Ron Myers. Ron is going to go through what I think is definitely a patient-centered approach to educate and to support patients with the decision of lung cancer screening. Ron has done incredible work in colorectal cancer decision-making, prostate cancer decision-making, and he's now tackled lung, I think, in an absolutely beautiful platform. So Ron, please go right ahead and educate us on the process and program that you've built. Thank you.
Well, thank you very much. I hope you can hear me clearly.
Yes.
Peg, thanks for that very nice introduction. And it's a pleasure to be a part of this meeting and to see many of the names and faces that I've been familiar with over the years. I want to share with you today some information about lung cancer screening and work that has taken place that I believe helps to set the stage for an exciting future in relation to lung cancer and lung cancer screening. My name is Ron Myers, of course, and I'm the director of the Division of Population Science at Thomas Jefferson University. And if we go to the next slide, we have at Jefferson been working as other institutions have been in the lung cancer screening space for a number of years. And we have developed an approach which we consider to be a learning community approach that has the capacity to bring folks together around important health problems, and in this context, lung cancer and lung cancer screening. What you see here is engaging a learning community to achieve the promise of lung cancer screening, which is the title of a white paper which we are literally poised next week to to announce and disseminate. So if we go to the next slide. Sorry for the movement of these, some of the numbers on this slide. This is, again, many of you may know these numbers as well or better than I do, but lung cancer incidence in the United States, Pennsylvania, and Philadelphia County are displayed here, and mortality rates are shown here as well. And you can see that Pennsylvania has a higher rate than the national rate for lung cancer incidence, and Philadelphia County is particularly hard hit. And if you look at mortality rates, comparable rates for Pennsylvania, the Commonwealth, and the United States, and again, Philadelphia is a bit of an outlier, having a substantial burden for lung cancer mortality. Next slide. Again, you may be familiar with these guidelines. The Center for Medicare and Medicaid Services, CMS, put forward its guidelines for lung cancer screening in 2015, and you can see the criteria that are applied in order to identify persons who are eligible for lung cancer screening. And I will note, as part of these guidelines, shared decision-making is a required element of lung cancer screening, required for the reimbursement of screening services. Just recently, the United States Preventive Services Task Force updated its guidelines, the 2021 guidelines, broadened the age range for individuals who are eligible for lung cancer screening, reduces the number of pack years of cigarette smoking exposure, includes a recommendation for shared decision-making, and also adds a criterion that has to do with the absence of comorbidities. These are the current guidelines, and if we go to the next slide, one of the questions becomes, well, how do we, as a nation, how do we as a Commonwealth, how do we as health systems actually operationalize these guidelines and address the need to increase lung cancer screening? Well, there are really two models. Tabriz et al. Wrote and published a recent paper, and I was privileged enough to be able to review the paper and write an editorial that there are decentralized screening models, and many health systems rely on their primary care physicians or specialists to identify people who are eligible for lung cancer screening, to educate them, and you can see the boxes here that kind of capture the different elements of lung cancer screening. And tobacco treatment is also, of course, included here. Those folks who are found to be eligible, who receive education and decision support, and choose to go forward with low-dose CT scan, then go forward and have their results. And those who have a normal test result would continue with annual screening. Those who would have an abnormal result would go through follow-up evaluation. So that's one model, a decentralized model, and that's actually the model that is used most commonly across the country. If you go to the next slide, there is an alternative model, a centralized model, and that model is based on the notion that a health system, for example, would establish a centralized program, and patients would be referred to that program by their primary care physician. Patients could self-refer to the program, and specialists, of course, could refer to the program. On the left side of that diagram, this is kind of like the starting point, and that responsibility for identifying individuals who are eligible for lung cancer screening still falls on those primary care physicians and specialists largely. And then the rest of those activities can be completed by the referring physician and or handed off to the centralized screening program. And a similar process unfolds. In some instances, some health systems, you see that kind of centralized model paired with a decentralized model. So there is there are hybrid models out there, but these are the two basic models that are used. And if you look at the application of those models, and you look at the patients who are eligible for lung cancer screening and go through those steps, what you see is that patients who undergo screening and are diagnosed with lung cancer, as compared to those patients who do not go through screening and are diagnosed with lung cancer, the distribution of stage is dramatically different. If you go to the next slide, this is an example of the impact of a centralized program. Thomas Jefferson University supports a centralized program. And if you look at the cases that were diagnosed in the context of this centralized program over this period of time, you see on those 40 cases, almost 66% of the cases that were diagnosed as a result of screening were found at an early stage. What you see in Pennsylvania, and indeed nationally, for cases or patients who do not go through screening and are in a kind of community setting, for example, the numbers are really almost literally reversed. That is, roughly 70%, 65 to 70% of those cases would be found with late stage disease for those populations not going through screening. So you can see the potential value, the potential impact of lung cancer screening, and in this context, a centralized program, certainly not the only kind of program, but the dramatic impact it can have on the stage of disease detected. If you go to the next slide, please. Well, how are we doing nationally in relation to lung cancer screening? Here in the Northeast, we're actually doing better than many other parts of the country, but I would submit that a 3 to 4% screening rate among those who are eligible is not so great. I think we can do, and ideally we'll find ways to do better. And then as a result, be able to confer the benefits of screening to larger numbers of persons in different populations. So if we go to the next slide. Healthy People 2030, and again, many of you have seen these this information, really calls for us to do a better job of reducing the lung cancer death rate. And they have, we're looking at a baseline and the target for reduction put forth by Healthy People 2030. And then the idea is that how do we get there? One of the things we can do is increase the proportion of adults who receive lung cancer screening, and nationally, and they're looking at this national guideline. Again, perhaps not surprising, but for many people it is surprising. We only have less than 5% of adults actually getting screened. And they have put forward a modest target of trying to raise that rate to 7.5%. Go to the next slide. In our own Pennsylvania Cancer Control Plan, Goal 11, and again, I'm sure you are all familiar with this, this part of the plan, there is a strategy that has been outlined on the left side here, promoting the importance of lung cancer screening and empowering those who qualify, developing and promoting a patient navigation case management programs specific to lung cancer screening, and I would harken back to that notion of centralized and decentralized programs, promoting the resources available to health professionals. And you can see the rest: educate health professionals, establish a shared decision-making process, and establish an integrated multidisciplinary teams approach to delivering those services. I would perhaps submit that we may think about those multidisciplinary teams as part of what I would call a learning community. And the goal here is to go from where we are or were at roughly 22% of cases found with early stage disease to increase that. And I would again submit that I think this is a modest goal that we may be able to exceed if we commit ourselves to it. So if we go to the next slide, the operational question here, of course, is we know where we are, or at least we have a pretty good feel for where we are. How do we get to where we want to be? And if we go to the next slide, we have, and again, I introduced this at the beginning of the talk, we have developed a white paper at Jefferson engaging a learning community. and you see a web address at the bottom. You can go to that address and directly access a copy of that report. If we go to the next slide. This report has been generated as a result of a 4-year effort that we were fortunate enough at Jefferson to receive funding from the Bristol Myers Squibb Foundation to develop this initiative. And we are, 3.5 years through this process. And our aims have been to engage a health system, in this instance, Jefferson, and health plans in the greater Philadelphia area, patients and other stakeholders, in what we call a lung cancer learning community, or LC2, which you'll see, and develop effective outreach and intervention strategies that can increase screening and catalyze support for implementation, and ultimately, of course, evaluate the impact of doing that. Next slide. What do we mean by a learning community? Well, I won't bore you with the theory, but there is theory behind this collective impact model, and many of you may be familiar with the interactive systems framework. And this says that health systems can identify important health problems for patients and populations they serve and engage a number of constituencies in the process of actually addressing that health problem. We have organized and operationalized this framework by putting together a coordinating team, as you see here in the middle, a strategic management team, a system leadership group from leaders of the health system and health plans, a steering committee, patient and stakeholder advisory committee from primary care practices, community organizations, advocacy organizations as well. And you can see the other groups that we've put together. When you put all of these folks together, if you were to put them all together on a Zoom call or in a room, hopefully in the future, this is more than 100 people have come together over the past several years in order to make this project run. And that's what we consider and think about as our lung cancer learning community. Next slide. So what has that lung cancer learning community done? And if we go to the next slide. One thing we did at the beginning was to conduct some interviews with the health system leadership, with health plans, or insurers, private insurers in and around the greater Philadelphia area, and stakeholders, which included constituencies that I mentioned earlier. And we asked the questions in these interviews, what do you think we could work on in order to make a difference? And the consensus of those interviews came to kind of identify these particular bullets. We should think about how we could come together and support this learning community infrastructure. And actually think about it not just in relation to Jefferson, but any health system. Let's think about how we might be able to do that. Let's think about sharing resources and interventions that might actually work here. Improve the assessment of eligibility, which is actually a problem. Some of you know that relying on the electronic medical record to get PACURE information on smoking exposure is really challenging. We may be able to figure out how to improve that. Conduct cost analyses to kind of think about how we may be able to sustain this effort. And speaking of sustaining the effort, develop new value-based contracting that could support screening, and advocate for investment in lung cancer screening. So these were the ideas that our interviews generated. And if we go to the next slide, we then thought it would be important to actually do an assessment of whether there might be support for these activities. And if you go to the next slide, we pulled together 25 individuals from across these different groups. And we were really pleasantly surprised to see that there was very strong support for moving in this direction, which gave us a compass, so to speak, to help us navigate the future and going forward in lung cancer screening. Could we go to the next slide? Part of what we did then as part of this effort was to identify an effective intervention to increase lung cancer screening. To do that, we brought together 4 primary care practices that serve very diverse patient populations, identified patients through the EMR who were potentially eligible for lung cancer screening, and allocated them or randomized them to these groups that you see. I'll point to the third group on the right under randomization, an outreach, contact, and decision counseling group. This integrates shared decision-making into the process of contact. And all of these patients had were part of a primary care practice and were potentially eligible. We only contacted a subset of those individuals to verify eligibility. And you can see the results of these intervention strategies. Usual care, only about 2% of those potential eligibles underwent screening. And in the OC group, the outreach contact only group, where we made a phone call saying and assessed eligibility and said, are you interested in screening? Only 4% of those potential eligibles screened. And in the OCDC group, where we actually took patients through a shared decision-making exercise during that outreach call, 7% of them, of those potential eligibles screened. So that's not bad. It actually approaches the 7.5% goal, but there is a statistically significant difference between the OC group and the DC group. So that's a good thing. But if you really drill down on it and look at the individuals who were actually eligible, we were actually able to achieve a 40% screening rate among those who were defined as eligible. So I think this gives us some hope that this kind of intervention strategy might be quite useful in addressing issues related to increasing lung cancer screening. Next slide, please. The other thing that we did, or another thing that this grant helped us to do, was to develop a shared decision-making training program, working with the American College of Chest Physicians, the GO2 Foundation, and the National Lung Cancer Roundtable and others. We actually developed a 3-module online educational program, which we will also be launching next week. That will be made available across Philadelphia, across Pennsylvania, indeed across the country. This online lung cancer screening program will be available to help train clinicians and care coordinators and others to do those bullets that you see below: identify persons, educate persons eligible, and help eligible persons to make a well-informed shared decision-making program. And of course, this program also informs or addresses the issue of those persons who have a smoking history or are currently smoking. Next slide. We will offer this training program, which satisfies CMS guidelines. It's a 60 to 75 minute seat time for a learner to go through the program. And currently, we hope that care coordinators across the state and across the country will take advantage of the program, and healthcare providers, specifically primary care physicians, nurses, and specialists, will have an opportunity to go through this program. And it's an accredited program for those learners. Next slide. Part of that program includes this information that can be downloaded and shared with patients for an educational experience, provides information about what happens for people who do go through annual screening and those people who do not. Next slide. For those people who are identified as individuals who have an abnormal test result, here are some data for patients so that they know what they may be getting into in terms of the follow-up and or recommendation for annual screening. Next slide. And there's information in here about overdiagnosis, safety of lung cancer screening, potential costs, and the importance of quitting smoking. If we go to the next slide. And included in this one-page infographic, there's an opportunity for a provider simply to assess whether patients are interested in screening or not, or to what extent they are. And if we go to the next screen, we have paired this one-page infographic, which will be translated into multiple languages, with a tool, a one-page tool that physicians can use in order to guide patients through a shared decision-making exercise. So if you go to the next slide, this training program is when you think about this training program with the learning that we achieved in terms of identifying a strategy that we may be able to use in order to engage patients in screening, you can see that we have the possibility or the potential when we think about a health system. How could a health system, we can address the question of how can a health system support the implementation of lung cancer screening more effectively than we are now? We can train primary care physicians and care coordinators in this, using this shared decision-making training module. We can identify patients who are potentially eligible for lung cancer screening. And if we pair that with patients who have a scheduled office visit, we can then think about supporting primary care physicians and care coordinators in engaging patients before the office visit and at the office visit. This may be a very effective strategy in terms of engaging patients in health systems to think about and walk through the process of making a decision about whether or not to participate in lung cancer screening. Go to the next slide. So that's an overall strategy that we can consider, and we will be able to make all of these tools available literally across the country and even around the world. But then how might we be able to do better? Well, perhaps we can even do better if we work with health systems to identify primary care practices in areas of need. We may be able to then target the dissemination of these training and support materials to practices that and other organizations, health organizations, that serve the needs of patients in those areas. And we should think about how, in the context of health systems, how we can even improve the EMR so that we can actually do this much more efficiently. So these are some things that we can do to either to improve or enhance this basic strategy that we're thinking about. Next slide. Of course, an important part of this is to not just engage the health system, the primary care practices and the health plans, but the community as well. So this is another element of our learning community that we have addressed, and we've brought community organizations and community members into the learning community to be part of the process of developing this strategy. Next slide. So that's all, in a sense, preamble to giving you a clear sense of the proposals that are included in this white paper. And if we go to the next slide, we propose that health systems, all health systems, should consider organizing a lung cancer learning community that can guide collaborative efforts related to lung cancer screening and smoking cessation and the reduction of disparities relative to lung cancer. This model that we have developed is not the only model, but it is certainly one that we've had experience with and would be happy to share. Next slide, please. We think that health system learning communities, and again, I'm not placing all of the responsibility on the health system. If a health system can catalyze the development of these learning communities, then those learning communities can help to guide this process of encouraging health systems and plans to identify individuals who are eligible for lung cancer screening and ensure that shared decision-making, lung cancer screening, smoking cessation are offered at multiple touch points in care. And we have the tools, and we have the training program available to do that. If we go to the next slide. The third proposal, and again, this is a tip of the hat to the need to think about sustaining this effort. We need to think about the cost and bring health systems and health plans and others into the process of figuring out what the costs are, what the return on an investment is, and how we may be able to implement these things in such a way so that we can sustain the effort, not over the course of a year, but over the course of multiple years going forward in the future. And you can see some of the costs associated there in the box below. Next slide. Our fourth proposal in this white paper is to suggest that we need to do a better job of advocating for increased public and private investment in lung cancer screening and smoking cessation. And if we go to the next slide, This is a table that is included in the white paper that lays out lung cancer funding in Pennsylvania. And at this moment in time, and I don't think this has changed much, there is a relatively small amount of lung cancer funding in Pennsylvania that is dedicated to address issues related to lung cancer screening. I think we can do better. And one of the questions is, how can we do better and what are the implications of doing better? If we go to the next slide, this is just a little snapshot of what we see in the Jefferson, Philadelphia, Greater Philadelphia area. In this period of time, roughly 6,700, 6,800 patients were screened through that centralized program. If we think more broadly about and this was, if we think more broadly about the patients who are eligible for lung cancer screening or potentially eligible for lung cancer screening in just Jefferson Health primary care practices, that number is something on the order of 60,000 patients. And if we were only able to engage 10% of those patients, those who were eligible, of course, in lung cancer screening, that number is then 6,000. And think about that as potentially an annual number. Broaden that picture to Philadelphians, just Philadelphia County. You can begin to see the numbers increase. But then if you look at the region, you can again see those numbers increase substantially. And the benefits that we have seen and shown some earlier slides of those folks who would be identified through screening, the large overwhelming majority of them would be identified at an early stage where we can actually see the implications of lung cancer screening in terms of survival, in terms of mortality reduction, and in terms of cost reduction. So this is, I think this is my last slide. If we go to the next one. I want to thank you for your attention to this presentation. I hope you do have an opportunity to access the white paper. We have a strategy, a plan. We have the tools. I think we, and I say we as a Commonwealth, have an opportunity to think about how we may be able to facilitate the development of learning communities and health systems across our state, and be very happy to hear your questions and thoughts and recommendations as to how we, again, as a Commonwealth, may be able to proceed. Thank you.
Ron, thank you so much. That was incredibly comprehensive. And we really appreciate you taking the time to review the patient side of all this. We do have several questions. Kate, do you want to facilitate questions or do you want me to?
Either way, Peg, we can certainly do that. Ron, I can do that, Peg, if you'd like.
That'd be great.
Sure. So Ron, there was a couple of comments and questions in the chat. So Nate, I don't know if you'd prefer to come off of mute to read those out and ask them directly to Ron. If not, I can go ahead and read that. So the first is, I'll just kind of read this if that's okay.
Sure.
Since radon is the second leading cause of lung cancer, also synergistic risk with tobacco, smoking, and is radon exposure attributes to about 12 to 14% of lung cancer incidence, it seems that elevated radon should be a factor for lung cancer screening. PA is a high radon state with with radon levels 40% in the homes of Pennsylvania residents at about 4.0 PCI-L. It is possible to address radon in lung cancer screening program.
So let me first, say that it's absolutely clear that radon is an important causal factor relative to lung cancer. There's no question about that. There's also no question that that issue is an important issue to address in the Commonwealth of Pennsylvania and elsewhere. Our project, because we were focused on lung cancer screening, didn't directly address the issue of radon. And part of our focus was on criteria for identifying individuals who are eligible for lung cancer screening that were defined by the CMS and the U.S. Preventive Services Task Force. And unfortunately, at this moment in time, radon exposure is not identified as a risk factor that is to be used in order to identify individuals who are eligible for lung cancer screening. So that's why we focused on this issue. That having been said, however, I think if we were to embrace the idea of developing learning communities in health systems, those learning communities, in my view, should include in their patient outreach and educational efforts the issue of radon and how it may be able to be addressed in the context of those patients, those populations, and those geographic areas that are served by the health system. I hope that answers the question. If not, I'd be happy to say more.
Thank you. And it seems like, just for some further discussion, Nate has provided his email address in the chat, so we could just make sure that gets to Ron. And even with his other comment, you kind of addressed that too with some preemptive action related to radon testing and the strategies that you are doing. So thank you for that. Just if we have other questions or comments or things that you'd like to ask, the floor is yours. You can either come off of mute or continue to place that information into the chat.
So Ron, I would ask, if you had to move forward with one grant that you think would help the most in furthering this discussion and evaluation, what would it look like? What would your hypothesis look like?
Well, let me suggest that if we, and I think this is maybe a multi-level kind of response. If we were thinking about a kind of demonstration project, for example, and we were thinking about a demonstration project that would involve the process of developing a learning community in health systems. We have started that process at Jefferson, and we aim to continue that. But of course, there are other health systems, such as those health systems that serve the greater Philadelphia area and even the southeastern Pennsylvania area. One of my thoughts would be that we could begin the process of working with those health systems. And we have begun dialogue, actually, I should share. We've begun dialogue around this issue with the University of Pennsylvania, Temple University, Lehigh Valley Health Network, Penn State Health. We've had conversations and preliminary discussions with those organizations about the process, this learning community paradigm or model. So if I were thinking about a demonstration project, I would potentially think about this as a project that could address needs in southeastern Pennsylvania, not to be too parochial. It doesn't have to be that. But thinking about southeastern Pennsylvania, bringing these 5 health systems together around this issue of establishing lung cancer learning community in each of these health systems, and then putting forth a process with those systems to educate primary care physicians and care coordinators to identify patients and guide them through lung cancer screening. And then if we were able to do that effectively, using the intervention strategies that we've seen to work, we may be able to actually see substantial change in the near term in terms of screening rates, stage of disease detected. Ultimately, obviously, mortality is a longer term endpoint. But if we were able to implement that kind of demonstration project with one or more, I'm thinking of those 5 health systems, that would be an outstanding beginning and we would be able to generate a substantial amount of information that could, and methods and procedures, process and outcomes that could potentially be of great value to other health systems in other parts of the state, of the Commonwealth, and potentially even more broadly than that. So that's at least a beginning of an answer to the question. And again, it's multi-level, multi-layered, and I'd like to ask for your thoughts or other thoughts about that possibility.
Yeah, Ron, you've done such coalition work in the past. I don't see as that. I think that's the easy part, right? The tough part is narrowing down the metrics and the means of true analysis.
Yep.
So I think that's going to be where, everybody has to come to some type of agreement, and you finessed that in the past.
Yeah, I think from the metrics point of view, the identifying the numbers of persons who would be identified, the actual success in contacting those individuals, the assessment of eligibility, the number of people who would choose to and not to screen, the individuals who would go through screening and the results of screening. I think all of those are metrics that can be developed and applied, and we have experience in doing all of that.
Great. Any other questions?
We have another that came in through the chat. So Ron, I'll read this out. This came in from Jean Lingrich from Penn State Health, just asking what ROI or economic figures we would use in talking to Penn State Health. So if you could share a little bit from your perspective to him, that would be great.
So I'd like to ask for just a little bit more clarification what we mean by economic figures. I'm not quite sure.
Sure. Jean, if you wouldn't mind coming off of mute and sharing a little bit more, that would be wonderful.
Yeah, can you hear me, Kate?
Yeah. Hi, Jean.
Hey, Ron, long ways away. Great presentation, really good proposals, lots of food for thought and for improvement in health. I guess from a health system perspective, not just Penn State, but from a health system perspective. So when we speak to those board members and such, what sort of return on investment or economic figures would go along with the great health improvement that this sort of model would bring to it?
Yeah, that's a great question. We have run some of those numbers within the context of Jefferson as to the costs associated with operationalizing this kind of learning community, operationalizing the screening effort. And I don't have those data to share with you right now, but there is a substantial return in terms of the procedures, payment reimbursement for procedures that are done, not just screening, but the diagnostic follow-up and treatment. There is substantial return on investment to the health systems for implementing or increasing screening rates. The other part of this process that is important to do, which we're now doing, is catalyzing a discussion with the payers, CVS, Aetna, Independence Blue Cross, Humana, Cigna, others, to begin to talk about the costs as it relates to the possibility of developing and modifying value-based contracts to sustain the effort. So I think that's one thing that is often, surprisingly, often overlooked, is the importance of engaging the health plans in supporting preventive health behavior and this kind of initiative. So I think there's, and of course there are papers out there that address the cost effectiveness of lung cancer screening, and lung cancer screening compares favorably to other preventive health behaviors. So I think it's again a multi-level kind of response, and I'd be happy, offline to share with you or talk with you about some of the numbers that we've been able to generate. I just don't have them ready at hand today, but I'm happy to share some of that information. But in my view, it's a process, but it's an important process to address, both from the health system perspective and from the health plan or the insurer perspective. This has to be, these folks have to be part of the learning community approach that we implement, it seems to me.
Yeah, I agree completely, Ron. I think it also presents a nice model for training future physicians too and learning.
That's a great point. Yeah.
Yeah. And then I guess the final thing that I would say is that, I think the issue of prevalence of higher smoking rates among individuals also could be a factor in how this gets deployed, so that we target these learning communities, this whole system approach within a health system or within a geographic area or a particular population.
Yeah, well, it's interesting that you bring that up because in the centralized model, and again, not all health systems utilize a centralized model, but in centralized models of persons who are referred to screening, tobacco treatment is part of the model and part of what the range of services that are made available. In a decentralized setting, that the identification and referral of patients for tobacco treatment services falls essentially entirely on the practitioner, on the physician, who might or might not identify an individual as eligible for lung cancer screening. And more broadly than that, of course, it's important to do a community-based effort to educate the population and to support and make sure that the resources that can support tobacco treatment are made broadly available to persons from diverse populations. So that clearly has to be part of the process. And again, we've tried to address that issue by bringing those constituencies to the table, especially in terms of our steering committee model, our steering committee component, and our patient stakeholder advisory committee. So great points, Gene. I appreciate you raising them.
Yeah, I don't want to take away from the centralized importance of this, but just realizing that a new system, a naive system, may want to approach this from sort of a stepwise fashion or pilots or something like that.
Yeah, no question about it.
Wonderful, thank you. Do a call out for additional questions. Let's see, we got another one in the chat. I'll go ahead and read this. Are there any employer component? Is there an employer component to this approach? And just is there a sustainable increase in coverage where the employer is responsible for coverage and payment? So the question being an employer component to this approach, Ron.
Excellent point. In the context of the model that we've developed, we haven't focused attention on an employer patient population or employer population or employee population. It's certainly very reasonable for a health system to think about bringing folks their employees into this kind of model. I think it's also important, although we haven't specifically broken that out, is to identify employers in a particular geographic area who might want to identify or be part of a process of making lung cancer screening services available to their employee population. That is a constituency, the employer constituency, that frankly we haven't actually brought into the model that we have developed, but I think is an important addition that makes a lot of sense to bring in. And then I wouldn't say that employer would necessarily be offering the services, but would be part of the process of making either a centralized or decentralized lung cancer screening services more readily available to their patient population. And I would include other educational information such as smoking or tobacco treatment and radon information available to the employee population. So I think it's an important addition that should be considered.
That's great, thank you. Other questions or comments? Lots of praise in the chat, Ron, for a really just wonderful, informative presentation.
Well, I really appreciate the opportunity to share some of these thoughts and ideas, and welcome, offline conversations and any feedback from the CAB as to future directions we may be able to consider taking or be part of considering as we think about meeting the needs of the Commonwealth population. So thanks again. I really appreciate the opportunity to share with you this morning.
Absolutely, and thank you. All right, so I think if I'm looking at the agenda, Peg, and correct me if I'm wrong, it's time for a brief break.
Mhm.
All
Yeah.
right. Oh, I'm sorry, go ahead.
No, please go right ahead. I want people to think during the break about opportunities for this particular program in conjunction with your own. And Ron, thank you again. We really appreciate it. So we'll take a 15-minute break, Kate?
A 15-minute break, so that opportunity to check email, go get a drink, what have you. I'll also do another call out for folks if you are joining into the PCC component of our time today. If you could do that registration, that information was provided in the chat kind of at the top from Monica. So just if you haven't pre-registered, that would be very helpful if you could do that, just to help get you to the selection of a work group of your choice. So just do that quick call out, but as mentioned, let's take that quick break and we will reconvene right at 10, we'll do 10:45 where we'll hear a little bit about our annual survey. So we will talk again in about 15 minutes. So 10:45, please join on for the next component of our morning. Thank you. Hi, everyone. Just given the 5-minute warning, we'll start again in 5 minutes with our information on the annual survey. So thank you. See you in 5 minutes. All right, I'm going to start welcoming us back so that way we can promptly start again at 10:45. So do we have everybody ready to go for the next section of our agenda this morning? Sharon and Heather.
I'm ready.
All right. Well, I will turn it on over to you to kick us off and talk a little bit about our annual satisfaction survey. Thank you.
Thank you, Kate. I just want to say to everybody, thank you for your wishes. People have been chatting to me and sending me emails, and I do appreciate that. And it has been a real pleasure working with everyone for the past 11 years in rebuilding that to what has become an ideal coalition and everything that we've been doing. So I know some of you are thinking of, I know you're sitting there thinking about, even during Ron's presentation, what kind of expensive retirement gift you can get me. The best gift that you can get me at this point in time is to help us make our annual survey goal. If you see on the screen right now that number, and you're going to see, and for the next month while I'm still here, I'm going to be pounding everybody with this number of 130. Because what our goal is to try to get as many of our coalition members as possible to do the survey. Come on, you can give us 10 minutes. Instead of buying me a new Porsche or a trip to Disney World or something, take 10 minutes out of your day and please do the survey. To tell you a little bit more about the survey, I'm now going to turn it over to Heather Vatson. She is our evaluator from PHMC who does all the behind the scenes work. So again, this is going to be the best retirement present you can give me. So Heather, turning it over to you.
Okay, thank you, Sharon. It's always hard to follow up, Sharon. But yes, the annual survey is a very important evaluation tool. It helps us understand how the PCC is functioning. And we use those numbers and report back to the staff and the co-chairs on the executive team. It allows us to let the CDC know what's been happening in the past year, and it allows us to plan for the coming years ahead. However, even though the PCC membership has been rising in the past few years, the participation in the survey was staying about the same at about 40-ish people. So this year, the evaluation subcommittee, in coordination with Sharon and the Cancer Control Program staff, created this ambitious goal of 130 people. So as of 10:38 a.m. this morning, we had 71 surveys, which is 55% of the goal, and it exceeds our participation in the past several years. This is great, but there's also still a ways to go. So our plea today is the survey takes about 10 minutes. Could I see the next slide, please, Kate? But it's really helpful for planning and understanding what's going on with the PCC functioning. The executive team really takes the findings and comments very seriously and tries to adjust based on what you say. So it really is something that will have an impact for the future and try to address all of the issues that are raised, if not immediately, then over time. Sometimes it takes a little bit to address some issues. We will not be doing a meeting survey after this meeting. This is the only survey that you have. So it would be great if you could participate in it. Kate, can we take the rest of our time in this segment to allow people to do the survey, or do we need to move on?
I think we are right on time, Heather, so we can go ahead and do that. And if
Okay.
you want me to advance to the next slide to give that link?
Yes. If you
QR
advance to the next slide, you should be able to click on that link there, but I'm also going to put it in the chat in case you have any problems. And you can also use the QR code if you want to take it on your phone. The survey will be open until next week at this time. but I would love to be able to report back at the end of the PCC portion of this meeting at the end of the day that we have much closer to 1:30 than we have now. So I'll be quiet now and let folks take the survey.
Yeah, Heather, I'll just add to the guilt factor here. If you care anything about me, you'll do the survey.
Sharon, that is wonderful.
Hey, guilt always works.
Wonderful. So again, to our folks who have yet to take the survey that are on the call today, please go ahead and do that either through the link or the QR code and really help to get to that goal. So as Heather mentioned, she's going to go ahead and check us as we move forward to see how we are inching up against that goal. So we are going to come back to the agenda at 11 o'clock. And so then at that time, Peg, I'm going to turn it to you at 11 to introduce our next speaker. So one of the things so Heather, I agree with you with a playlist, that would be certainly wonderful. And if you have taken the survey, again, a thank you. If you want to kind of continue to utilize the chat to send our congrats and shout outs to Sharon, that would be a great use of our time here. But to those that are taking the survey, the gift to Sharon is also completing the survey. So we kind of got a twofold depending on where you are with your survey submission. Thank you.
Yes, don't send me a chat unless you've done your survey.
So we have about 5 more minutes to go. So hopefully you're still thick in the completion of that survey if you haven't done that already. But to those that are kind of waiting for the top of the hour with us, just wanted to give that time countdown. See you in 5. Sharon and Heather, any final words to the group about the survey before we transition to the next part of our agenda?
Nothing from me. Heather?
Yes, I just wanted to say that the survey will be open until the 25th, which is next Friday. So if you weren't able to do it now, please make sure that you do it then. I can see that there are some in progress now, but we have gone up a few, which is very exciting. So I hope to see it jump into the 80s by the time that later in the day. And we will send out one final reminder next week.
Great.
And I think that's it.
Wonderful. Thank you. All right,
Thank
Peg, I'm
you.
going to turn it back over to you, and I'll advance the slides to the next component of our agenda. Peg, are you there?
So sorry, was on mute. Next presentation will be Eugene Langrich, who will present under the Penn State Cancer Institute, looking at a strengthening of patient navigation, multiple types of navigators in Pennsylvania through engagement, education, and research. Eugene, please go right ahead, and thank you so much for covering this topic. This is something that the coalition as well as the CAB has been trying to engage and enrich throughout the last few years. So your topic is very timely. Thank you very much.
Good. Thank you, Peg. So can you hear me?
Yes.
Okay, good. And you can see the slides, I assume, because I can, so that's great. Thank you.
Yes.
So yes, I'm Gene Langrich. I'm from the Penn State Cancer Institute, and I have the pleasure of directing the Office for Cancer Health Equity and also being the Associate Director for Health Disparities and Engagement for the Penn State Cancer Institute. This presentation is not by myself at all in any way. I'm just kind of here to get us kicked off and to jump in at a few places as we go forward. But I have a couple of colleagues that I want to have or will be making part of the presentation here, and I will introduce them when we get to those individuals. So can we have the next slide, please? Great, thank you. So we're here to talk about CANSUN, which is the Cancer Navigation and Survivorship Network. This is an effort to strengthen navigation in Pennsylvania through engagement, education, and research. And you can see a couple of the names of my colleagues here that I'm going to introduce a bit later on. Next slide, please. So our agenda is fairly brief here. So first of all, we want to give you a little bit of background on navigation in Pennsylvania, give you an overview and history of CANSUN. It's not a long history, but it is an important one to appreciate. We hope to have a lot of discussion about next steps and questions and answers. So please save those up. We will be monitoring the chat and be happy to have some discussion here. We do have a couple of prompts at the end that we will use to stimulate that discussion. Next slide. So there's a problem. That problem is that too many minority and medically underserved cancer patients in Pennsylvania are diagnosed at a late stage or have delayed initiation of treatment when that treatment is less likely to have a positive outcome. And here I pulled a few stats just from PA Eddie. Thank you very much for the data here. But 30.5% of Black patients with breast cancer are diagnosed at a late stage, way too many. And as we heard from Dr. Meyer before, lung and bronchus patients, 69% of Hispanic patients are diagnosed at a late stage. And in another screenable cancer, colorectal cancer, 60% of patients in Juniata County are diagnosed at a late stage. And for those of you who may be not familiar with Juniata County, where it is, but it's in the south central part of the state. It's a very rural county, does not have a hospital. And so it is an important representation of our rural Appalachian population. Next slide, please. I don't have to convince anybody in this audience that patient navigation is an evidence-based solution. The duties and the responsibilities of a navigator are pretty obvious to other people. To the people in this group here, you'll see it spread throughout the Pennsylvania Cancer Plan. So the navigator identifies and addresses barriers to prevention, screening, diagnosis, or treatment, and then assists patients moving through those services, particularly in a timely manner. And one of the common metrics that navigation programs have used is the time from initial diagnosis to the initiation of treatment. So timing is an incredibly important component here. They play a central role in the healthcare team as well as distributing community resources and providers. Next slide, please. Now, the way we think about navigation, particularly in the context of CanSun, is navigation is a process, not necessarily an individual who does it. So it is typically provided by at least one person, but it may involve a whole team. And we also recognize that these navigators don't necessarily need to be a person with formal healthcare training. Those individuals might be individuals that have the title of a community health worker or a promotora, for example. And as I said before, they identify and then help meet the needs of individual patients. They often play a central role in the healthcare team as well, because they touch the lives of the patient throughout the process. Next slide, please. Here's just a quick representation of the barriers that a navigator may encounter for a particular patient. There may be logistic ones, such as transportation, economic, financial assistance, being able to make appointments with providers, just overcoming fear, enhancing communication. I was just talking with patients a couple weeks ago, and they weren't aware of navigators at all. And I think that when we have a Spanish webinar series, and we did one on cancer patient navigators, and the majority of those individuals that were on that webinar weren't even familiar with that terminology. And of course, they're there to overcome cultural and linguistic barriers also. Next slide, please. Here's another representation of how that navigator functions within providing care for patients, overcoming barriers to empower those patients and provide support, with the ultimate goal of reducing late-stage diagnosis and delayed treatment. Next slide, please. Well, navigation is sprinkled throughout the Pennsylvania Cancer Plan. As we went through the plan, we identified it in a number of places. The first place was in increasing health equity, Goal 1, Strategy 2, and 5. Also in the area of increasing cancer screening, breast cancer, cervical, colon, prostate, they were all listed there. It was also mentioned that it is a COC standard 3.1, and there was also a call for training and certification. Next slide. So when we did a real quick scan of the health system and statewide barriers to navigation in Pennsylvania, we came up with a number of specific barriers. These barriers have arisen from the training and activities that we've done in its early stages of CanSun, part of which we did under funding from the Department of Health. But there's particularly limited communication across health systems. This is, I think, particularly relevant to me in the rural areas, because patients come from quite a distance to a hospital, health system, and then return back. And often when they return back to their home, they're engaged with a different set of providers and that are in a different health system. So I think there's limited communication across the health systems because the health systems care for their own patients. Sometimes services are limited to patients of the health system. We often see this particularly in cancer centers, where they really have a focus upon the patients there. Just frankly, there's too few navigators then as well for what the function that they serve. They're undervalued, and we particularly hear this across the board But I guess I'd like to call it out specifically for those that are serving in the area of community health workers or promotores, because oftentimes those are volunteer basis. Navigation services may not be billable, particularly for certain patients. That we hope is changing. And it may just be deployed late or only when problems arise, such that when we have a late diagnosis, then we employ the navigator to determine what the problem is. And I think that really defeats the whole concept of cancer control across the cancer continuum. Next slide, please. So at this point, I want to turn the presentation over to a colleague, Nirmal Ahuja. Dr. Ahuja came to us about 3 years ago when he entered our Doctor of Public Health program at Penn State. He achieved that degree in just last year, 2020. He majored in the health systems organization and policy. His focus was, his thesis was focused upon social support and medication adherence. So he got good exposure to this concept through his thesis work. Currently, he's working as an assistant professor for population health and health equity at Harrisburg University of Science and Technology. So he moved from Penn State, got his degree, and moved not physically too far, but to Harrisburg University. I think this is a great opportunity because it demonstrates the expansion of our cancer focus from just the cancer centers and health systems, but into other universities that may not be a part of the cancer discussion so frequently. He grew up in India, where he obtained his medical degree, and after that he got his Master of Public Health from Northumbria University in the United Kingdom. He has over 10 years of public health research and practical experience while working for various national and international organizations. So as part of his work in our office a couple of years ago, he conducted this paper that he's going to be talking about. If you remember back a couple of years, he actually came to this group and sought your input. So you all had some of you did take advantage of it, but had the opportunity to provide input into this paper, which was part of his work in his DRPH. The other thing that I would mention about Dr. Ahuja is that in his very short time at Harrisburg University, which just started back in September, he and his colleagues have acquired funding from the Department of Health, not specifically in the cancer area, but from the Department of Health for statewide health improvement activity. So he's a co-principal investigator on that funding, and I think this represents another opportunity to bring together some efforts that aren't just under the cancer umbrella, but we're looking forward to working with him as he moves that project forward. So Nirmal, do you want to take it away here?
Thank you, Gene. Thank you for this introduction, and thank you everyone for this opportunity. As Gene mentioned correctly about patient navigation, it has been going on in Pennsylvania since many years. However, when we thought of actually writing this paper, the first thing which came to our mind was about a policy. Can there be any kind of a policy solutions to improve access to Pennsylvania's complex system of care, and how do we go about it? And that's where we decided that we would focus on something like a white paper or a policy brief which highlights the benefits of patient navigation, especially in cancer-related care across the United States, and also which is already existing in Pennsylvania from different perspectives, from a research perspective, from cost-benefit perspectives, how it's been beneficial to the healthcare institutions or hospitals or organizations, and then maybe suggest some kind of a policy solutions which can definitely help in improving patient navigation and cancer-related care across Pennsylvania. So this paper is focused on those aspects. So the next slide, please. So few of the national examples which were mentioned in the paper, it speaks about how patient navigation has been utilized effectively across different states in several for benefits. Like, for example, Colorado affirms and recognizes patient navigation since 2006, and they have partially funded it through state health agencies' tobacco tax. Then there was another study which was published in American Journal of Nursing, conducted in urban community health centers. It showed really high screening rates in patients with patient navigation services. And that's why it's important not to maybe allot patient navigation benefits to the patients when they are diagnosed in the later stage, but right from the early stage, because it helps us in improving the screening rates. In fact, apart from that, the Michigan, the Breast and Cancer Control Navigation Program since 1991 has screened over 600,000 women and diagnosed over 4,800 breast cancers and over 6,000 cervical cancers just because of patient navigation. Then in University of Alabama, which conducted a cost benefit study, it actually found that the costs were declined by $781 per patient per quarter per navigated patient. An estimated benefit was about $19 million across the network. That was a benefit actually because of patient navigation. Next slide, please. There were a few examples which were also mentioned about Pennsylvania. In Pennsylvania, the UPMC provides individualized assistance to patients, families, and caregivers throughout the healthcare experience. Highmark Foundation also conducted a study where they found that navigation was associated with 43% reduction in non-emergent emergency department use and 60% reduction in 30-day readmission. Definitely that helped in reducing the financial penalties. Penn Medicine, 20% patients assisted with navigation across all types of cancer were more likely to stay for the treatment. So these are just few examples. Of course, Penn State Cancer Institute has been involved since many years with patient navigation, and it has benefited to many patients with regards to the cancer network, and also with training of several patient navigators, which I have personally witnessed during my time. Next slide, please. So I would like to focus more on the recommendations which were part of this paper. The first and most important recommendation, because we all know there are many people. It can be community health worker, it can be social worker, it can be promoters, it can be called as patient navigation. Some other the way individuals do offer patient navigation services to the patients. However, in this particular paper, we recommended and we proposed a state legislation to define the term patient navigation and patient navigator. Be in mind that this particular definition already exists in the Affordable Care Act, and it's important that the state comes forward and as part of the state legislation. Another recommendation was to include the state and private health insurers provide reimbursement for patient navigation services, because as Jean also mentioned previously about the billing of patient navigation services. The third recommendation was to urge public health advocates to integrate patient navigation language into local and state healthcare reform legislation, because that's important aspect which can actually take this forward and benefit a lot of patients. The fourth was a standard set criteria for qualification and training of patient navigators, because right now everybody is involved in training, but it's important that we have a set criteria for that. The fifth recommendation was employers support patient career development and formation of state and local patient navigators network. And I believe CANSON is an important step in terms of developing that kind of a network for patient navigators, and it will definitely benefit. Finally, employers and funders recognize patient navigators' contribution to the public health infrastructure, because they definitely not only help the patient, but also contribute towards increasing the screening rates, and also in return benefiting the state, benefiting the organizations by saving the cost, improving the screening costs, reducing the cancer morbidity and mortality in future. So those things should be considered while developing certain kind of policies with regards to patient navigation. I think I'll hand over it to Kate, who will speak about CANSON next. Next slide, please.
Yeah, can we have the next slide? Let me go ahead and this is a good opportunity for me to introduce Kate. So Kate Conkle came to the Office for Cancer Health Equity in April of 2020, just over a year ago in the midst of COVID. She is the lead health educator for our office and the Penn State Cancer Institute. Prior to coming here, she had over 10 years experience in working with communities to improve health and advance equity. She spent the 11 years at the University of Wisconsin Population Health Institute. She worked on statewide and national projects focusing upon building partnerships to improve health. She was the program manager for the Healthy Wisconsin Leadership Institute. And an important part of her history, she was also a community coach and later team director for the community learning for the County Health Rankings and Roadmaps project. Probably many of us are familiar with that. Some of us may be more familiar with the data that they provide. That's my experience, but they've also been very instrumental in providing specific assistance to states to develop their efforts in community health improvement. And for them, she was a community coach and later as a team director, as I said. She does have an MPH degree from the University of Alabama at Birmingham. And we were happy to get her back here because she has her bachelor's from Penn State University. So she's, I'm glad she's back to being in Pennsylvania here. And I guess I also want to mention at this time that another person that's involved with this is Samantha Curio. She's on board here today. She is an MPH student and she's going to be involved with further development, particularly the environmental scan for CanSun. So Kate, welcome.
All right, thanks, Jean. So I'm going to talk a little bit now about the Cancer Navigation and Survivorship Network, also known as CanSun. And next slide. So I want to start by acknowledging the steering committee, who's been a huge part in guiding the effort to relaunch the network over the past year. I really appreciated and valued their insights and perspectives. So a big thank you to this group, which includes navigators, social workers, community health workers, navigation program managers. As you can see, we have people from the State Health Department, from American Cancer Society, so people with both local, regional, and statewide views. And next slide. So I wanted to start with a bit of background and a brief history and overview of CanSun, how it started, where things are headed. In 2018, CanSun launched with a series of patient navigator trainings. They were in person when that was a thing. There was a newsletter, password protected community forums, and a resource guide on the website that at that time mostly focused on Dauphin County and surrounding counties, because at that time the network was really focused on the Penn State Health catchment area. In 2019, the Office for Cancer Health Equity was formed. And at that time, there wasn't a dedicated staff member for CanSun, and so activity was a bit more sporadic, and it went into a bit of a dormant period. So as Jean mentioned, in 2020, I came on board as the lead health educator providing staffing, albeit a small one, for CanSun. I started with some key informant interviews, and then from that formed the steering committee to really inform the planning for what is now CanSun 2.0, I guess. And now here we are in 2021. We wanted to make sure that we were coordinating with the Pennsylvania Patient Navigator Network. Karen Schwaderer, who is part of the steering committee, was one of the founders of that and a big part of the volunteer force behind the PPNN, and that was a network was a really important connection point for patient navigators throughout Pennsylvania. However, without dedicated resources and with an all-volunteer leadership team, it was a challenge to keep it going. So as CanSun was kind of getting back off the ground, we decided that we could provide some of that infrastructure for a navigator network. And so we've absorbed really the professional development and communications activities of the PPNN. And as we build the network, we're also deploying short surveys to better ascertain both who's part of the network. Again, lots of people are performing navigation activities, so just getting a better understanding of what their roles are, where they sit, who they're serving, and all that stuff. And then a better understanding of the learning and networking interests and needs. So we hosted a kickoff in April, and we had another network meeting at the end of May that focused on transportation challenges. That came up in that kickoff meeting as something that everyone's really struggling with. And then our next meeting is next Wednesday, actually, from noon to 1, and it's going to focus on metrics to show value. And Karen and Angelique Saigan, who's one of our steering committee members as well, will be our guest presenters on that meeting. So next slide, please. So over the course of the planning process to relaunch CanSun, we developed our purpose and our vision, which are really the why behind why we do all this work. And they keep us moving in the same direction. So you can see the overarching driver is to reduce disparities and create better opportunities for access to care across the cancer continuum through navigation. So that's our piece of this huge pie in terms of reducing disparities and increasing equity and advancing equity. Next slide, please. So our mission, the way we aim to serve our key stakeholders, so the people working in navigation, then is to connect, educate, and share best practices among patient navigators in Pennsylvania so that together we can successfully reduce barriers and increase access to cancer prevention, screening, treatment, and survivorship services. So I want to reiterate here that when we say patient navigators, we're really talking about this more as a function than as a title. So this includes a broad group of people from social workers to nurse navigators, lay navigators, financial navigators, case managers, community health workers, promotoras, lots of people with different titles that are working across this continuum. Next slide. So some of the outcomes that we expect to see as we launch this network is increased navigator confidence in providing evidence-based patient navigation, increased or improved patient experience, increased social support and emotional support for navigators. You know, I heard in my key informant interviews that this is hard work and it's emotional work, and in some cases people are working in very siloed atmospheres, and so being able to bring people together that have a shared experience, both to learn, but also just to connect and provide support for each other, was something that I heard over and over again. And then greater understanding of the effectiveness of patient navigation among stakeholders. So again, from community and patients through health systems and payers and providers. We really want everyone to understand the value and effectiveness of patient navigation. So next slide. So how do we get there? So we've mapped out several strategies with input and feedback from the steering committee. We also look to other local navigator networks around the country, some regional, statewide networks, to see what they're doing and what sorts of activities and supports they were providing to their network of navigators. And we'll continue to hone these strategies with feedback from the network, but there's really 4 broad areas that we're working within. And those are connection, education, research, and advocacy. The work of the network really primarily falls into the first 2 strategies of connecting and educating, but we realize that we need to support the work with research and advocacy. So I'm going to walk through each of these in a bit more detail. So next slide. So in talking with navigators, social workers, community health workers, via the key informant interviews and in network meetings, one thing that I heard over and over is that people really want to connect. And I think maybe a function of this last year in particular, people really want to connect. Navigators are located in every corner of the state. In some cases, they're part of robust systems with lots of navigators. And in some cases, they may be the only one or they're part of a very small team. So CanSun's goal is to both, and can you click one more time there, Kate? And one more time. So CanSun's goal is to provide resources and professional development to navigators, but we also really want to make sure that we're connecting navigators with each other. So can you click one more time? There we go. You know, so that they can share expertise, best practices, and resources, as well as opportunities for warm handoffs or coordination between navigators, as Jean mentioned, people travel outside of where they live to get care, but they're still living in those communities, and they need resources that are both related to their care, but that also support their life back at home, and resources that they may need there. So next slide. So we're creating opportunities for connection in a few ways. We're currently doing virtual peer networking meetings. So these are focused meetings on a virtual platform, right now Zoom, with facilitated dialogue to share strategies and provide support. So again, we had the kickoff in April. We had a meeting on transportation strategies in May. Our next one is on metrics to show value. It's next Wednesday. I can share that registration information in the chat at the end. And finally, we heard from the first survey that there's definitely an interest in online community forums. And this is something that we really want to get launched so that people have a space to dialogue and share resources in an asynchronous way. They don't have to be available when the meeting's happening. We know we've had experience with people getting called away for different activities when a meeting was scheduled. But we also recognize that a community forum requires good management, so we want to make sure that we're building this in a good and in a way that's going to work and be meaningful, and kind of slowly adding on these different pieces as we go. So next slide. So we're also planning professional development trainings, again, currently virtual, although hopefully at some point in person, thinking about both statewide and regional opportunities in the future. Topics including everything from health literacy, survivorship, shared decision-making, social determinants of health, navigating the patient journey. Others, as we hear from users, from CanSun users and network members, what they are really looking for. We're working with Merck with their some of their trainings that they offer to be able to provide some of the trainings to the network. Currently, we also have newsletters. Right now, they do focus more on registration for upcoming meetings and sharing resources and recordings from past meetings. Eventually, really hoping to launch both more resource sharing, navigator spotlights where we can really highlight and celebrate the work of navigators and again, increase those opportunities for creating connections. We currently have about 165 subscribers to the listserv. Some of whom signed up a few years ago when CanSun first launched. About a third of them have subscribed, though, in the last, I would say, 3 to 4 months. And next slide. So finally, I'm going to wrap up here with, we really, again, see our role as the running of the network, which is really providing opportunities for learning and connection. But we also recognize that to truly strengthen patient navigation in Pennsylvania, we need policy and system support. We are just launching an environmental scan to gain a better understanding of the current landscape of navigation in Pennsylvania. We want to be able to share that with advocates, share with systems that are looking to maybe either develop or strengthen navigation programs, and to use as a baseline to really understand how navigation may change over the next several years. As Jean mentioned, we have an intern, Samantha. She's from the MPH program at Penn State, helping us with that this summer and likely into the fall. We're just now into the survey design phase and identifying really who exactly we're going to distribute the survey to. Really just hoping to get a better understanding of who performs navigation services, how many navigators are part of these different programs, how are they funded, what stage of the cancer continuum they address, where are they based, when were they established, who they primarily serve. So those are some of the questions we're hoping to be able to answer. And while we want to provide learning opportunities for navigators, we definitely know we have a lot to learn from navigators and view this network as an opportunity for bidirectional learning. So we've deployed one survey so far to get some additional info on, again, who's part of the network and what types of support and resources would be most useful. We'll continue to use surveys, again, in network meetings to gather information to guide both the direction and growth of the network, but to just get a better understanding of what types of support and what else may be needed even outside of CanSun to support navigation. So I think we'll also really be looking to other groups like this one to support some of the research and advocacy work that's needed. And with that, I am going to turn things back over to Jean to wrap things up and tee off our discussion.
Thank you, Kate. Could we have the next slide, please? So what does navigation in CanSun mean to you all in the audience there? So for navigators, this is an invitation. If you haven't already engaged with CanSun, please do that. you can contact Kate at Penn State Cancer Institute, and we will be providing contact information there. We also look for you to be able to share your resources and best practices, as she had indicated. For the Pennsylvania Cancer Coalition, so we had indicated before where navigation was mentioned in the cancer plan, and thankfully it's throughout the plan, but it is not specifically called out as an activity. And I think there's an opportunity there through CanSun and other efforts to be able to coordinate and to be able to record those efforts. So I think the opportunity here is to think about how can we coordinate efforts across the state. For the advisory board, there are obviously system and policy issues that you may be in the position to be able to address. We outlined a few of those in Nirmal's paper, but there may be others, and some of them may actually have moved along since that paper was published. So I would encourage the advisory board to think about the system and policy issues around navigation. For health systems and payers, again, enhancing services and reimbursement. This does overlap a bit with the policy issues as well. And I think that we also heard the issues of health systems perspective from Dr. Meyer's presentation earlier today. So that was a good introduction there. And for investigators, so there are a number of, we already have shown that navigation as a black box works, but I think there's a number of questions about what makes the effectiveness of navigation work, under what conditions does it work, for which populations does it work, and what outcomes we might expect to see. Like I think the economic issues is one that is always present. So being able to evaluate return on investment and what it means to a health system is an opportunity there. So I think there's, navigation and CanSun means a lot to many different people. So I hope you can find yourself on this slide here and think about your own role in navigation and CanSun. Next slide. So here are a few questions that I hope will stimulate some discussion. So what will success of CanSun look like in 2 years or 5 years? Kate is putting us on a path here to develop this, and the steering committee is weighing in on that. But I think we'd really appreciate hearing sort of what you think success would look like. And as I said before, how can navigation be strengthened within the current PA Cancer Plan? Moving beyond the provide, promote, use, engage verbs that are associated with a navigation concept in the plan. So what are the barriers and opportunities for moving this forward? What policy and system issues should be addressed and by whom? What navigation questions can be addressed through research? As I indicated, I think investigators have an important role in enhancing and furthering the navigation efforts in the state of Pennsylvania. So our next slide, please. And we'll probably come back to this one and leave it on. But so this is the opportunity for questions. And then the next slide, so that we don't miss it, is go on to the next one. Yeah, thank you very much for the opportunity to present. We really do appreciate it. So let's back up a couple of slides and put the questions up there. And this is an opportunity for you to weigh in here.
And thank you, Jean. We do have one question that came into the chat. So, just kind of the overall, if you do have a question, you can feel free to come off of mute and ask directly, or to just chime into the discussion, or to place into the chat. So I'll go ahead, Jean, and read the question that did come in through the chat from Kathy. So for the policy recommendations, do you propose these for both navigation through screening diagnostics as well as navigation through treatment?
It's a great question, Kathleen. I think that yes, I think the answer is yes. I expect that the navigation is going to look a little bit different for each of those processes. Typically, the the navigation through the screening process is performed by individuals who have less specific healthcare training, whereas the navigation post-diagnosis and into treatment and survivorship often have a healthcare training and certification that goes along with that. So yes, I do think that that would be different. Nirmal, do you? And we're all here on board, so Nirmal, please jump in if you've got more to add to that.
Yes, I agree. I mean, what you said, Gene. I mean, initially, I would say before diagnosis, more from the community perspective, navigation, looking at the community needs and what could be like what could we offer from the community side, or what are the benefits. I think we can look at from that perspective. And I think post-diagnosis, one who's trained in healthcare, like what onco navigators are doing it right now, I think from that angle will definitely be helpful. Yeah.
I wanted to thank everyone. This is Peg O'Grady. This was an incredibly helpful discussion. I also had a few questions. Have you ever thought that CanSun could link with AONN, which is the Association of Oncology Nurse Navigators, because they're looking for state reps across the country, and this would be particularly helpful, might give you a leg up with some funding as well as nationwide opportunities. And Lily's team has done phenomenal work in oncology. So both from an RN standpoint as well as a lay navigation standpoint. So I didn't know if you had connected with them in any meaningful way, or if you'd be interested in doing so. But your program very much mirrors the barriers and opportunities that they look at.
Yeah, I can jump in there. We haven't. I have at this point looked at kind of what the application process looks like. It's something that is definitely on our radar, and that is on our steering committee agenda to kind of discuss, is that something we want to move forward with? It does seem like there's a lot of benefit. We just want to make sure that we are understanding sort of what we're committing ourselves to as well. But yeah, and that was where, when I was looking at some of those other local navigator networks, and to see, what were they working on? What were they really what was their vision and mission? What kinds of activities they were engaged in? That was the resource that I really turned to, and we've reached out to them a couple of times as well, to AONN in general, just asking some general questions and getting information around survey design and other things that they may have deployed already.
Yeah, I can tell you, Abington participated in their initial metric study for navigation, and it was incredibly helpful. It helped us really look at defining software for barriers to care. It helped us with engaging other multidisciplinary staff members and understanding what our navigators do and their scope. And it really gave patients a voice because of the survey tools that they used to say, this is what I need from a navigator, which I think is just really powerful, and helps all the way around, making sure that patients continue on through therapy and treatment. Who's the handoff that navigation gives to when they go through infusion or radiation or surgical care. So I think you have a very wonderful program that can engage the state. And as far as the CAB is concerned, this is absolutely something on our radar. So your definition of how CAB can help you, I think the only barrier that the CAB would see is truly the scope and the data definition of navigation across the state. It is so varied. Holy cow, is it varied. So we just need to work together to move that forward with a true written document that will help. As far as, what you want to look at, I can tell you through the oncology care model and now through the radiation oncology care model, navigation is a fixture in both of those CMS plans. So you would do very well to look at both of those models of care and utilize that as a springboard for what navigation can help to support. Because Jefferson did a gorgeous job doing that. Val Chick is our coordinator, and man, oh man, she just really honed in on how navigation can help meet those metrics. So that may be something that you want to take a look at for another lecture another time. But anything that I can do to help move it forward, believe me, we'd be more than willing to help. You did a great job. Thank you.
Thank you.
Thank you, Peg. And also just to Lily Shockey. So one of the things that we did do is work closely with the Pennsylvania Patient Navigation Network, which I think Lily has come to and spoken to at a number of their, or several of their presentations. So we have individuals in the group have had that experience with her also. And then Penn State has also engaged her in advising our care plan as well. So we are in touch with her. But, you know, Kate is right. She has been looking at the AONN Plus group for guidance and history on becoming a network, a regional network as part of them.
Yeah. And if you want to do a statewide assessment, I can tell you genetics just did that for Pennsylvania, and that was incredibly helpful. So we looked at genetics counseling resources throughout the state. And the team that put that together was a team from UPMC and Geisinger. But that is something that's doable.
Great. I think we have time for just one more question that came in from the chat. What are your thoughts about engaging health systems? So navigators, care coordinators, social workers, and health plans, like health coaches in standardized training and certification?
Yeah, Ron, that's a great question. I guess what I would answer there is let's learn how to walk before we run. And so I think with the resources that we currently have, we've been more focused upon creating that community of navigators first. But I think that a next step or a future step certainly is working with the health systems. You know, and the little information that I have of what goes wrong in the state, I mean, the deployment of navigation through the various health systems is very variable. You know, Penn State doesn't have a very large network, but when we look at places like Allegheny Health Network, they have a very strong navigation network, primarily focused on cancer patients post-diagnosis. And then we look at other places like the Northeast Regional Cancer Institute, and they have a fantastic community-based cancer screening navigation program. We look at the American Cancer Society statewide navigation efforts. So I think the constellation of systems organized navigation is quite variable, and I think at this early stage, our first focus is to identify the individuals who are part of that, providing that service, and to provide the training, education, connection them. We'd be happy to talk more with you about your program if somehow this fits in there, but our primary audience at this point in time has been sort of the individual navigators and then working up to their health systems from that.
Great, and thank you. And there's still some questions coming into the chat. So Jean and team, I'll encourage you to look at the chat and see about maybe some respondents there so we can continue this very rich dialogue on this very important topic. At this time, to just keep us to time on this morning session, Peg, I'm going to turn it back over to you to take us to the last section of our morning together for CAB business.
Great. So the next lecturer is actually one of our distinguished CAB members, and she would like to be able to show us her Cancer Health Disparities video update. Dr. Dominic, if you would please go ahead.
Thank you so much. I sure do appreciate it. And again, it's an honor to be with you today. It's always exciting when we're able to have representation across the 67 counties to address cancer prevention and control. Back in March at our previous meeting, we shared with you an update of our ambitious project of creating a statewide video that addresses cancer health disparities. The video format and everything else included in the video is informed by you as well as our coalition, and it's also informed by our leadership. And today I want to just highlight a few things that we would like to share with you. And I will spend the first 3-5 minutes just giving you the high-level overview of what we discussed in March and where we are today, because we need you now more than ever. Things were delayed due to the pandemic. Again, 2020 was a very challenging year. It was a very disruptive year. And it really did attack individuals with underlying conditions, including certain cancers. So the forefront of cancer prevention and control is now highlighted using multiple media and leveraging technology. And this is one of the avenues that we are going to be leveraging for our video. Would you do me a favor and do you want to advance my slides, or would you like for me to advance them? What might be best? Okay, wonderful. So Margaret, do you have any of my other slides on there?
Aurelia, this is the only slide that we do have.
Is it possible for me to have control and share my slide deck, which is the remaining of that slide that you have?
Sure. And just Aurelia, and thinking about as we transition, we do have only about 10 minutes until we will close out this morning. So just want to share.
Yes.
So sure, I can stop presenting.
All right. So can you see my slide?
Yes.
Slide. Okay, and you're seeing now the same slide that you saw, correct? All right, correct. So I'm going to go quite quickly because these slides again are repurposed from our March meeting. This is information you already have, and just wanted for those who have joined us for the first time, we do have a project that is the CAB Cancer Health Disparity Video. It is in collaboration with their stakeholder, the PPC, and so I wanted just to highlight that we do have data input for this video. It's yourself, the CAB, the PCC, the DAC, Live Healthy PA, and of course our plans within the cancer prevention that we have for control. We're leveraging our burden reports as well as our plan. Today, I want to just highlight on the very last two, which is the budget and the participation that we're seeking from you. If you recall last time, it does have 4 specific goals. We also have a very specific approach, and that it would be featuring persons and images across the state. It's going to be capturing a statewide feel with 6 regions, and these regions would be aggregated so that it could become a very doable project. I mentioned to you again, the approach will have 4 sections: the video itself, as well as data from the DAC committee, as well as the Pennsylvania Cancer Control. These here are the official reports that are produced through our efforts here at the CAB and in Sharon's department and the Department of Health for Cancer Prevention and Control. There is always a connection and a touch point with the community. And this bridge is really made possible through the CAB and through the PCC. So this is a project that belongs to all of us, and we are very excited about working together. The third part would be leveraging the video that would include the stories of individuals and businesses in Pennsylvania that were affected by certain cancers, and those cancers priorities have been aligned with the same ones that you find in our burden reports. We also told you that it would have storylines about unequal cancer burden that's found in the region, about advances in modern medicine and technologies that allow us to have improved cancer prevention and control, experiences, and there's very specific experiences from risk reduction to addressing social determinants of health, age distribution, geography, underlying conditions, policies as well. And again, from an early detection and screening, there's some cancers that will be both in adult and children and adolescents, including childhood cancers, skin, breast cancer, colorectal cancer, lung, prostate, liver, and etc. In terms of prevention, we'll also be leveraging the genetic component for the advances in medicine that we now have in that space, and the control experience in terms of how do we have appropriate and timely diagnosis and avoid the crazy scenario of late stage diagnosis. And then the universal messages of what is personalized cancer from a genetic and a predisposition lens, as well as the translational models and innovation for cancer prevention and control. You've seen all this before. We said this is going to be a video, so everyone will be smiling because it'll be lights, camera, and action. We will be leveraging, again, the Live Healthy platform, leveraging technology, leveraging our PCC, our CAB, and all the touch points and service areas that you represent. The timeline, again, we were very ambitious and we said we would have this by the fall. In Q4, we were informed by experts in the media production, as well as experts from Monica Fisher, who is internal from the Department of Health, and her communications and leadership team, and each of you that have emailed or have met with us, including the adult rural Appalachia, minority, racial, and ethnic groups, and even in the childhood cancers, we had Aubrey also participate. In terms of the funding sources, again, we are focusing on this being a CAB and a cancer focused as opposed to a commercial, infomercial, commercial. We don't want to lose our important message just by a certain brand of a commercial. So it was advisable, and everyone shared with us here that we should focus on the 501c3 organizations and that highlight their stories and their raw and neutral position as opposed to just having it as a commercial. This obviously is going to be a professional video production, and just wanted to mention with you that we met with various media, everything from local radio stations, TV stations, to even WITF and former presidents of WITF, multimedia. We went straight also to highlight minority-owned businesses in multimedia and see what their thoughts were, was this able, and what the budgets would look like. I mentioned to you last time that it would include 4 videos in the 6 regions, and focusing again in our priority areas of African American men video, Hispanic and Latino video, rural video, and LGBTQI plus video, as well as the regions that are prioritized would be disparate regions, and of course including the rural Appalachia areas as well. The budgets, as I mentioned to you last time, could be anywhere between $3,000 to $25,000, and it still meets our deadline. This is what I'd want to update you on, is we are ready to move forward, and we have flushed everything out per se. But in order for things to move forward, it does need a budget. And this is where we are seeking your thoughts and your help and your commitment. I know in the past we said we need your help for the video development. If you wanted to share your story or wanted to highlight something, we should include for you to make that known to us. We also said if you had any resources that you could help us with, that you'd also make that known. And then, of course, we also needed a commitment from you to help spread the word the moment the video becomes materializes and it becomes our deliverable, that you would spread the word, that you would use it within your organizations, even at home and within the communities that you live in, and that if you had any questions, to email us. This update here is where I wanted to share with you the individuals that have been working closely with us, that have been engaged almost on a daily basis to bring the voice of the community, to bring your voice on the community. And this slide really is just a call out for help. Today, my report to you says we're ready, but money makes the world go round, and money is needed to produce this video. We want to tell you that there are resources that are needed. We do have funding opportunities, and we really need you to please help support this Pennsylvania Cancer Health Disparity video, the 4 videos, the 30-second messaging, all the platforms that it could be leveraged on. The package that's being put together, or everything that includes TikToks to 30-second text to even general 30-second video messaging that could be leveraged in any lobby or any upload of a video to the full-blown video. What we need you right now is the very last thing that I'm going to end my presentation with, and one is your help. We do need sponsorship the persons that have stepped up to the table so far are Pat from the Pennsylvania Breast Cancer Coalition. They have made a financial contribution of starting at $1,000. Aubrey from the American Childhood Cancer Organization has also made commitment, and we are working out to see what is the best way that partnership can help us. They are willing to do a fundraiser with us and explore options. Jean Langridge is the same at the Penn State Cancer Institute. Monica Fisher, again, within the Department of Health, who's our technical support. That thank you so much, Sharon, for that resource, is able to guide us and help us. But we also need money. And the $3,000 is our goal if we want to have the lower budget video. $25,000 is the higher limit, which is our ideal request. And right now, I just want to end by asking you a question and to use your chat box. Number one, can we count on you to help us bring this project full circle? And can we count on you or your organization for sponsorship? And it could be as little as $1, and it could be as much as 1,000 or 25,000. This again will be through 100% of the proceeds will be used for the video itself. And the video is designed where it can address multiple cancer sites, priority areas across the state, and more importantly, that it could be leveraged year after year, where it could be expanded in the future, and it could even be collapsed if we wanted to highlight just a couple of the cancer sites. But would you do me a favor right now and use your chat box to see if indeed, number one, you're able to sponsor in some capacity with a yes. You do not have to make a decision as to how or what. We just need to know who can we have a next follow-up meeting with, so that you will be invited to, so that we can flush this out as to what resources we have and what we can depend on. So you do me a favor. And
thank you, Aurelia. You are getting some response in the chat, so I'll just kind of direct us to that, and then to the call out that you did to the group. If you do want to seek more information, or just with the counting on for support, if you could just utilize the chat, that would be great. And Aurelia, thank you for providing your direct contact information if people aren't able to respond today, and able to do that maybe post meeting. So thank you very much.
Thank you so much.
Of course. And so at this time, Peg, if you would like to kind of close us out for the morning, and then transition back to me, and I'll take us to what to expect for this afternoon.
Sure. So we certainly wanted to thank everyone for the morning. I think that, Ron and Jean's team certainly is worth our review, our time, our effort, and our collaboration. Aurelia absolutely puts the heart of why we do this. It's all about patients in need, and how we can best help to support them with education and screening and prevention and detection and treatment. So I want to thank everybody so much for taking the time this morning. And then most certainly want to make sure that you please continue to complete your surveys. For Sharon, I cannot thank you enough for the incredible leadership you've shown this group for so many years. So go enjoy retirement, and let's have a good break and come back. We'll reconvene at 12:30. Thank you so much.
And thank you, Peg, and thank you to all that joined us this morning. And just a quick thing before you do take this break for lunch. As Peg mentioned, we will reconvene at 12:30 and promptly get started for our afternoon session. To get us there, I've said before, I know that Monica provided the information in the chat, but the call out again, that this afternoon we will be doing breakout. So, bear with us, as this does take a little logistics and a little dance behind the scenes. In order to support that, we are asking you to do that pre-registration by 12:20 to be part of a particular group. So if you follow the QR code that's right in front of you, and we will leave this up, or the link that was provided in your agenda and registration that you did receive pre-meeting, please do so before 12:20, so that way we could get you to that breakout session. So thank you. We look forward to having you rejoin at 12:30, and we will kind of redo the instructions and all of that good stuff. But thank you, and have a good lunch, and see you at 12:30.
Darby, are you on?
I am.
Hi, my lady. How are you?
I'm good. How are you?
I'm so excited you're here. So
Monica, before we do that, do you want to stop the recording for the morning and then move us to restart it for the afternoon so we don't have that lag time in between? I don't know if that is something you want to do.
And the